Welcome to the American Shoulder and Elbow Surgeons Podcast. I'm your host, Peter Chalmers, a shoulder and elbow surgeon at the University of Utah in Salt Lake City, and I'm joined today by my co-host, Brian Waterman, a shoulder and sports surgeon at Wake Forest in North Carolina. Brian, how are you?
Hey, Peter. Good evening.
Before we get started, I should mention the views expressed in this podcast do not necessarily reflect the views of the American Shoulder and Elbow Surgeons Society, the University of Utah, Wake Forest University, or any of the institutes of our guests. So today we have an episode on a topic that affects nearly all shoulder surgeons on nearly a daily basis, and a topic that remains the subject of some practice variability between surgeons. And this is the question of how long should the patient wear a sling after a rotator cuff repair? This is a real debate with pros and cons on either side. I think we all know that one of the biggest issues with the rotator cuff repair is it's got a lengthy and unpredictable healing, but the sling is a constant source of patient dissatisfaction with the procedure, and it creates all sorts of secondary issues like ulnar neuritis and atrophy and stiffness. So to discuss, we've invited two world-renowned experts that have really studied this topic with some depth. So first, from the University of Maryland, we have Dr. Mohit Gilotra. Mohit, welcome to the podcast.
Hey, Peter. Thanks for having me. I'm really excited about this.
Oh, thank you for joining us. And next, from Washington University in St. Louis, we have Dr. Jay Keenum. Jay, welcome to the podcast.
Thank you. Thanks, Peter and Brian. I appreciate the opportunity to be with you tonight.
All right, let's start at the beginning. So let's just start. Why would you want to wear a sling after a rotator cuff repair? Jay, tell me, what is like the basic rationale for why this might make sense?
I think the sling, in theory, is supposed to promote immobilization or be a reminder to not perform active motion. So you're supporting the arm with the sling. It's a reminder not to move the arm actively. And some people use it as a surrogate for immobilization. So in theory, the reason why you would do that is to protect the repair. So I think that the problem is people equate ordering a sling and instructing a patient to use the sling as something that the patient actually performs and follows through on. So there is value in educating them on the benefit of using a sling, but I think in my practice, it's more valuable to instruct them on avoiding specifically active range of motion. Like, for example, I typically have patients in a sling for 6 weeks after the surgery, but I tell them specifically that they can spend time out of the sling if they're sitting there relaxed, if they're awake, and they can protect the arm as long as they're avoiding active motion. And I am a proponent of early passive motion. So I spend time teaching my patients how to perform passive elevation and passive external rotation exercises. Some people use physical therapy to the same effect. So I think early passive motion is allowed. I think surgeons are taught to use slings to minimize active motion with the arm. The problem is when you start taking care of patients and seeing their understanding of the sling and getting a better understanding of their compliance, it's all over the board. So I think there's more value in educating the patients about avoiding active motion. And again, that's debatable even because there's some literature out there that has challenged that notion. We can probably get into that tonight. But I think there's value in teaching patients how to protect the repair. For me, that means avoiding active motion, doing gentle capsular stretching passively rather than true immobilization. And the sling is one mechanism that reminds them not to move the arm.
Jay, I want to make sure I understand you correctly because I think this is great. Do a little thought experiment for me. Imagine you have a perfectly compliant patient, the patient where you would tell them, do not actively move your arm. Would you say then this patient does not need a sling?
Yes. I mean, I think, and those people are relatively uncommon, but you do see patients that truly follow through with their restrictions. And when you see them at their 6-week visit, they've kind of forgotten how to move their arm, how to fire their muscles. They tend to be a little bit on the stiffer side. So I don't realistically expect them to be completely avoiding active motion, because honestly, in real life, there's always some gentle contraction of the tendon, whether you're gesturing with your hands, whether you're putting a shirt on, whether you're washing under your armpit. I'm trying to minimize active motion. So yeah, and I think along the lines of your question, allowing patients that are compliant to be out of the sling as long as they keep their elbow at their side, I think is perfectly fine. But I'm trying to avoid that early stress on the repair, because I've always been fascinated by some of that work by Joe Ionati, that where they did tantalum beads on the edge of a tendon repair against the bone, and they looked at the migration of the bead that happens over time on X-ray. And it's interesting to see that the major difference between a healed and an unhealed repair is actually the amount, not the amount of bead migration, it's how early it happened. So I think if the patients are contracting their tendon, pulling on the repair, the stitches are pulling through the tendon or compromising the repair a little bit, you get early movement of the tendon at the enthesis. And that's what I'm trying to prevent, because I know they all eventually stretch out or they heal in continuity, whatever term you want to use. They end up that way anyways. But if I can avoid that early failure, that early migration, I think that's important.
Mohit, tell me, this is before we get into the evidence about whether the sling makes a difference. Tell me, from a theoretical basis, would you agree this is the reason why you think patients should wear the sling, or why it could be theoretically beneficial?
Yeah, I do agree. I thought the sling is, I like the way Jay said it, the sling is a reminder to avoid early active motion. Think of our cuff healing as our stages of inflammatory, proliferative, and then later remodeling. That early mobilization, while the patient is in their inflammation phase, is important to prevent stress on the repair. And then the passive motion, though, is still important early on. So as you're getting into that proliferative phase and you're thinking about the organization of the collagen at the site, I think it's probably better oriented and better kind of organization of the scar with early passive motion. I like how we're talking about it, right? It's not the sling. The sling alone is not the sort of treatment. It's what the patient is doing without the sling on that we're really worried about. So the patient is in a restful state, an immobilized state, even with the sling off, that they're probably fine. And when we get into the data and all that, the use of the sling as a monitor is really as an associative property rather than a causative.
And Mohit, just to have a balanced conversation about this, we've talked about some of the merits and the protective effects of immobilization, particularly avoidance of active range of motion. But we also know there's some downsides. We've alluded to a handful of them. What are the worst issues that you see commonly in your patient population from sling immobilization, and how do you mitigate that?
Yeah, I think we mentioned the ulnar neuritis. Another big one is the scapula. Often the sling is in a lot of internal rotation and with this level of scapular protraction. And that scapular protraction puts the cuff patient, even like the anatomic shoulder replacement patient, at this kind of disadvantage and poor kind of hunched over posture. So a lot of the early exercises, even when they're doing passive motion, is focused on scapular retraction to counteract that poor posture that the sling can put you in.
Jay, any additional thoughts on things you commonly see in your practice and hacks to get rid of it?
I agree with Mohit that it's amazing to see the people that actually, whether they overly buy into not moving their arm or they're just plain fearful of moving their arm, they'll come in for a later post-op visit and the scapula is protracted, the elbow gets stiff. Like I've seen patients where they can't straighten their elbow because they've just spent all this time in a sling. They're starting off their next phase of rehab with a very stiff capsule, and they're behind the 8 ball. So I frankly don't immobilize any of my patients, even the larger cuff repairs. I teach them a very simple 2 exercises that almost anybody can do. It takes a few minutes to do it, and just it's a closed kinetic chain passive elevation and a passive external rotation. And I think if you educate them that they can be out of the sling, keep their elbow at their side, and go ahead and straighten the elbow, get used to using the hand. If you kind of show them that it's okay, and the brain starts firing the elbow, moving the elbow and the hand, they kind of break out of that cycle of, oh my God, I can't move my arm at all. Because some people really do buy into that passive motion, or they're just afraid to move it. It hurts too much, or they're afraid they're going to damage their repair. So you have to walk a fine line, because some people are a little bit too anxious prone to even move their arm because it hurts.
Okay, so we've talked about pluses and minuses. And then I want to start with you, Jay. Now, Jay, you've studied this problem with the most rigorous experimental design known, a randomized clinical trial, extremely difficult to execute. And yours is one of a couple, but it's a particularly well done one. Tell us, like, what motivated you to do that study, and what did you find? I mean, I know it's been a couple of years, but I think everyone should know about it. So tell us about it.
Yeah, we did a randomized trial of about 140 patients that all were under age 65 and had a degenerative posterior cuff tear less than 30 millimeters in diameter. My impetus to do the study is my 2 partners, Dr. Galitz and Dr. Yamaguchi, were immobilizing all their cuff repairs, like strict immobilization, sling, don't move the shoulder, maybe just some passive elbow motion. And I am a physical therapist, and I've always felt like in my own patients, if I immobilized them, they were stiff, they were more painful, they were behind the 8 ball when they started their motion. And I wanted to see if it was safe. And I wanted to know if there were any differences in early clinical outcomes, because I suspected as time passed that at 1 year there'd probably be no difference between the groups. So we randomized all 140 patients. It was a big study. It took about 18 months to recruit them. There were 2 groups of treatment. So they all got sling use, but one group was strict immobilization, no formal therapy, no home exercises other than elbow, wrist, and hand. And the other group was early passive motion. And in this study, which is a little bit different than what I do now, they went to formal therapy. So they went to therapy twice a week, at least once a week, but preferably twice a week. They were instructed with passive motion, and they went to the therapist and were stretched. And then we followed them at the usual time points, 6 weeks, 12 weeks, 6 months, and 12 months, and 24 months. And we looked at their pain scores, their range of motion. That was probably the biggest endpoint we looked at. And then we looked at healing by ultrasound. And what we found really at the earlier time points, the range of motion was slightly better in the early passive motion group, but it wasn't statistically significant. At 1 year and 2 years, the clinical outcomes were the same. Very high ASES scores, I think it was 92, I believe. And our healing rates were very good, 90% in the early motion group and 94% in the immobilization group. So basically really high healing numbers, probably better healing numbers than we've ever had. And I think it was because we had a pretty homogeneous cohort of younger people, small to medium sized tears. They all got double row repairs. And so it was all very regimented from the get-go. But what I learned from that study is there's probably a subtly better motion and less pain in the first 3 to 6 months if you let them allow passive motion. But the final outcomes at 1 and 2 years, there's really no difference. And it's interesting, when we went through the study and published it, It didn't change the practice of myself or my partners. They continued to immobilize the shoulders, saying it's not really negative on the final outcome. People finally get their motion back, and I continued to do early passive motion. So it kind of proved that either was effective, and we didn't see a huge difference at any time point. Certainly at the traditional longer term time points, no real difference clinically or statistically with healing or outcomes.
Well, so you downplayed as though it maybe didn't matter because it didn't change practice, but I think it's valuable to show that both routes are effective. And certainly, I've always looked at that study and thought, my goodness, you guys are good at rotator cuff repair. I mean, the outcomes and the healing rates are so high, it's incredible. But tell us, you mentioned in the middle of that that's not your current practice. So what is your current practice? How does it differ from what you did in the protocol of the study?
So in the day, in modern, I guess in today's landscape, there's more capitation by insurance companies on a number of physical therapy visits. So I'd probably say 7 or 8 years ago, I just started showing patients their passive stretches to do at home. So they do pendulums, which is technically not passive motion, but it's kind of gravity assisted, active assisted motion. They do the passive elevation stretch, and they do passive external rotation 3 times a day, beginning at week 1 when I take their stitches out. That is their protocol with no formal therapy, continued sling use. And then I see them back at 6 weeks. At 6 weeks, if it's not a large to massive tear, I start active range of motion. And then we get rid of the sling. We wean from the sling. We start active assistive and active motion with a physical therapist. The passive capsular stretching can be more aggressive at that point in time. On a small to medium tear, or maybe an acute larger tear that comes together beautifully, I will start strengthening at 12 weeks. If it's a poor quality tissue or a large to massive chronic tear, I usually won't strengthen until 16 weeks or 4 months. So my protocols are very similar between the different tear groupings, if you will, except for the timing of strengthening. So that's just my protocol. I do use therapy, but for me now, it doesn't start till 6 weeks.
And Jay, how do you establish the passive range of motion parameters? What's the safe range? Is that something that you've just kind of happened upon, or how have those been informed over the years?
That's a good question. I really don't think that there's a limit. I don't think there's a danger in passive elevation if it's done the right way. If the muscles are relaxed, we know that on a posterior cuff repair, you're stretching the anterior capsule, the inferior capsule, but you're not tensioning the repair by going into flexion or scaption as high as you want. And with external rotation, that's the motion that hurts a little bit more than this closed chain passive elevation stretch that I show them. The external rotation, I usually tell them to go into the pain and hold it for 10 seconds and then come back and repeat. So I encourage them to go into the pain. I encourage them to keep the muscles relaxed. I also know that if I've done an infra repair, the external rotation, they really have to be passive with that arm. I don't want them trying to assist with their external rotation. So I have them use a cane or a golf club or something in the opposite hand to stretch the arm. So I encourage unrestricted elevation, unrestricted external rotation. And I think, most people by 6 weeks, if they demonstrate their closed chain elevation, they're in the 130 to 140 degree range, and the external rotation is usually between 20 and 40. So they're stiff, but they're not crazy stiff. And I think that's the sweet spot. I don't ever want to see a patient back at 6 weeks that has no stiffness, because I know that they're either not following the rules or they've probably compromised their repair already.
Yeah, those are sage words. And I definitely want to get into the stratification aspect, preoperative stiffness and some other things, but that's helpful. Mohit, on your
Jay,
side, you've also, go ahead.
yeah, I just had a quick question about that, because we know that, from multiple studies that 6 week and sometimes even at 12 weeks, that some residual external rotation passive stiffness is probably a good thing. It correlates with higher healing rates. So what do you feel like it is? Is it stiffness is protective of healing, or are people who are healing are naturally stiff? Does it go hand in hand? Is one kind of leading the other? What are your thoughts about that?
I was going to ask you that question because I have my own theories and I don't know, but I really think that people that are stiffer, even the ones that are really stretching, I think they have a greater inflammatory reaction to the surgery. There's more proliferation or inflammation at the repair site. Their capsule's more inflamed. They're just they tend to be a little younger. We see it in partial tears too. Partial tears, if you take it down and repair it, in my practice, those patients, now, of course, they're a little bit younger, but typically, but they tend to be stiffer than a full thickness, medium size tear that's repaired without tension. So I think that it's a surrogate for a better healing response, actually, is being stiff. You have a more pro-inflammatory reaction. That's just my guess, but I don't know. What are your thoughts?
Yeah, I agree that it goes hand in hand, but I don't know why. Are the stiffer patients automatically protecting their repair? But like you said, are the stiffer patients the same ones that have a greater inflammatory response? So that means that they're healing. But I do think that they auto protect. Like you said, you take them with passive motion, and, to where they can tolerate, with some minor pain, and that natural early stiffness sort of is protective of healing. If we think that's kind of the order of how it happens.
And Mohit, I think that dovetails nicely with some of your work on how sling use affects the rotator cuff repair. Can you tell us a little bit about what motivated your approach to this and what you found?
Yeah, sure. Early on in practice, I was sort of frustrated by kind of the overall heterogeneity and how patients were using their sling, where some folks felt like they weren't wearing it at all, and some were wearing it. It seemed like almost too much. And then, some of those patients who weren't wearing it at all would come back with complications, whether cuff's not healing or cuff's got failure osteoanatomic or something. And I wondered how much that was really playing a role, because we still had plenty of patients who were wearing it and doing fine. So I guess the beginning of the project, we just wanted to figure out what was the actual truth. Not what the patients told us they were doing with the sling, but what was actually happening. And so we went the temperature sensor route, kind of similar to what's been done in the past with scoliosis and back braces. Also was done with clubfoot and the foot braces for infants. And so we kind of validated these temperature sensors for slings. Basically, the idea being that if the sling is juxtaposed to your body, that it equilibrates with your body temperature, and we can tell that a patient is wearing their sling. And so we first kind of validated it with some healthy volunteers to get an idea of how the algorithm would work in a sling as opposed to a back brace, and to make sure that we wouldn't get any false positives if the sling was in the trunk of a hot car in a summer day in Baltimore. And after we figured that out, then we started just prospectively looking at patients' behavior, no kind of treatment changes, just get an idea. And I guess what we found, to be brief, is that, we were right. There's a large, kind of widespread use of the sling. In general, people wear it more early on in the post-op recovery and less later on, with kind of just basic instructions. In general, kind of the male gender wore it a lot less. If you had a higher BMI, you wore it a lot less. And then we found interesting things kind of on the social side. Like if you had home assistants, like someone else living with you at home, then you were more likely to wear in the daytime. But that didn't affect nighttime wear at all. And there was no correlation at all with what the patients said they were wearing and what they actually did. Majority of patients way overreported, but there were still a minority of patients who actually way underreported as well. So it's just fascinating to learn what the truth was about sling wear.
And then to transition to now your current practice, we've heard a little bit about Jay's side. How do you approach sling immobilization? Is it the same? Is it one size fits all, or do you have a little bit more of a stratified effect?
Yeah, kind of a stratified effect. We were curious, we got all this data about who wears their sling and who doesn't, but it was hard to figure out how much that affected outcome. Like, was there even an association? And so there is some of an association, but it's very loose. And so in general, if you wore your sling more, you had better pain scores early on, but later on it didn't matter. If we looked at radiographic integrity, so this was an association of reverse patients and anatomics and cuff. In general, wearing your sling a lot didn't matter, but wearing your sling close to none did matter. So if you barely wore it at all, like a very, very low use, less than on average 12 hours a day, that did affect your outcomes. So there's some kind of like floor effect of sling wear. And it's probably more that you're barely wearing it all and what you're doing with it off, but we can't prove that. And then from my practice standpoint, Jay's paper really affected how I think about it. So I start early passive motion on my small and medium tears after the first post-op visit. But for the big tears, I wait a month and then delay my therapy from there. So I do passive motion for the first 6 weeks, after that until 12, and strengthening at 12. And then if it's a big massive tear, then I'm less sort of risky, and I just delay everything by about a month.
That's great. It's very interesting to hear that there's some gradation, that there's wide variation in how patients use the sling, and that the super user, if I've understood you correctly, Mohit, the super user is not necessarily better off, but it's the people that don't wear the sling at all that's a problem. Would you say that's all true?
Yeah, I think that's a good way of saying it. Then we took kind of an introspective approach after that. We're like, maybe we're just really bad at explaining this, because there was such a widespread of how people were using it. So we were asking patients, like, why are you wearing the sling? What's the reason? And the folks that had a very sort of poor understanding of, yeah, I'm wearing it for healing, I'm wearing it just because my doctor told me to, the ones who could barely even come up with a response like that, they were the ones wearing it the least. We're currently in an RCT now where we're like, well, maybe if we're better at explaining it, maybe not just the sling, but everything, narcotics and passive motion and everything, maybe we can get better buy-in. So that's kind of ongoing now, to say if we think the main reason for non-compliance is us as the teachers, then maybe if we can add a video component or just kind of better instructions, and that we can improve that kind of thing. Don't know yet if that's true.
I love the idea that, that maybe the reason patients are sling is they don't understand why it matters, and that ultimately that responsibility rests with us. I wanted to ask, there's a piece to that I think we haven't really explored yet, and that's this. So this is something I've never understood. So we repair the infraspinatus, which is external rotator, and then we immobilize the patient in internal rotation, where the repair is theoretically under like maximum tension. So I want to ask both of you, like, why not immobilize the patient in external rotation? Like, would that help to take tension off the repair? Or is that, we do that, for instance, people do that sometimes with lower extremities transfers, with other tendon transfers, people have talked about it. Would that have made a difference, or is that such a fool's errand because we can't get patients even to wear a sling in internal rotation? What are your thoughts, Jay? I'm not sure you've thought deeply about this.
I think that's a good question, honestly, because you're right. I don't typically immobilize in neutral, but I'll be honest, most of my larger tears, the infraspinatus comes over pretty well. I don't think it's under a tremendous amount of tension. If it is, I will put them in a pillow. and the pillow keeps them out of extreme internal rotation, and it abducts the arm. It usually takes some tension off the supra. I'm more likely in my practice to have a tensioned supra repair than an infra repair. So I think I do use the pillow as an extra. I think people. I don't know what Mohit thinks about this, but I think when there's a pillow on the sling, the compliance is probably greater. They certainly don't like it; they complain about it more. But I think their ability to protect the arm is a little bit better. Maybe I'm falsely believing that. I know it takes some tension off of the supra repair, and it probably takes a little bit of tension off the infra. So if I don't trust the patient or if the repair is under some tension, I do use the pillow. I use it for about 4 weeks, and I still allow them to do their passive stretching because I really think those exercises that I show them are safe as long as they're not recruiting the muscle.
What do you think, Mohit?
Yeah, I think you're right, Peter, biomechanically. You know, when you're asking the question, I was harking back to that paper about bank car repairs and immobilizing them in next rotation and how that leads to a better, hypothetically, a better kind of tension on the bank car. But in the U.S. population, that wasn't true, probably because people just are all over the place. And so in Baltimore, I can't get patients to do almost anything I feel like I asked them to. So probably biomechanically, I think you're right. But could we get it to matter clinically? I don't know, because it's just like another instruction that's hard for patients to employ. You know, for example, for like tendon transfers, often we'll use the big abduction sling, you know, with the big pillow. And I think patients probably wear that even less because it's so bulky and unwieldy. So if I think I want to use a sling in that way because it's better for healing, but the sling is so sort of big that patients wear it even less, I'm actually hurting them by fixing them in a or forcing them into a sling like that. You know, I don't know, but it's like it's just hard enough to get folks to wear it a little bit.
So what I'm hearing from both of you all is that you think the infraspinatus is fairly tolerant of an internal rotation position, and the supra, I agree, it tends to be the one that's under maximal stretch or tension. What about the subscapularis? Does that play into the algorithm here, or you think we can hug the turns in the same way? For instance, with your passive range of motion, Jay, external rotation.
I typically on a subscap repair will still perform the same exercises unless it was really under a lot of tension. I do think that the subscap actually heals a little faster. There's a better blood flow to the area. You don't have that same watershed zone of dysvascularity that you see in the rotator crescent that you see in the subscap. So I've been comfortable as long as I can mobilize the tear and pull it over without much tension. If I can repair it in at least a neutral rotation with the arm, letting them do some passive external rotation, I might limit them to 20 or 30 degrees, but I just want them to stretch their anterior capsule. And I think the subscap repair can generally handle that. The subscap is also very hard to protect. If you watch people, it's you use that a lot, whether you're buckling your pants or pulling up your underwear or just little things as you bring your arm to your body. There's a fair amount of activity of the subscap. And I bet you that people are stressing that repair more than any of us care to think that they are, whether they believe it or not. But it seems to heal at a pretty predictable rate.
And Mohit, with regards to folks that maybe have some degree of occult adhesive capsulitis, or you get in there and it's really thickened capsule, is this a scenario where you'll alter your rehab protocol or sling immobilization in that scenario? I'm curious because I encounter that quite often. Some folks will take a staged approach, some will do a release, others manage their post-operative rehab a little different. I'm curious about your expertise on this.
Yeah, if I have a patient who has preoperative stiffness especially with the examination under anesthesia, then I am aggressive on the front end about a concurrent release, especially if with the rotator cuff repair. But then from a rehab standpoint, starting early passive motion anyway on most patients, so that part is staying the same. However, those same patients are at higher risk for having delayed stiffness. So like we're saying, the 6 weeks, the 12-week patient is frequent to have extra rotation 20 to 40, but that patient often will still have stiffness even later, at 6 months. And maybe at that point, I may have to do something else like an injection or something even more. I think that patient is at high risk no matter what you do. And I'm hopeful that the early capsular release can minimize their later stiffness. And I'm starting early passive motion anyway.
I think you bring up a
One
good.
thing that sorry, go ahead.
Yeah, I'm sorry. Just to segue on that, we all see patients that have either partial tears or very small cable intact, full thickness tears that are just frankly stiff preoperatively, and I don't indicate them for cuff repairs. I like to resolve their capsular stiffness prior to surgery, reevaluate them, and see if they even feel like they need surgery. Certainly, we've all seen patients that have partial tears that you treat their mild frozen shoulder or their posterior capsular stiffness with a well-placed injection and some therapy, and they're pain-free. Like they still have their partial tear or they still have their small full thickness tear and they feel dramatically better. So if somebody has a higher risk tear, so it's traumatic and they're presenting 2 to 3 months later and they're kind of stiff, and I think there's harm in delaying the surgery. The tendon's retracted. It's a big tear. I agree with Mohit. I will fix them, but I will be aggressive. I will manipulate their shoulder and release their their anterior capsule at the time of surgery and just make sure that I get them moving early on. So it's very common to see. I mean, we all train residents. It's very common to see people follow the MRI report, not closely examine the patient, and falsely assume that the quote unquote cuff tear on the MRI is the reason why they're there, when in fact, a lot of times they have capsular stiffness.
One of the things that I think is interesting is the sling is a. Go ahead. Sorry. Please.
Sorry, just off the quick. I'm with you. I think that's why the examination anesthesia is really important. If in the rare patient that we've improperly indicated, we want to know that in the OR so we can do the best thing for the patient. So the smaller partial cuff tear, who actually is a capsulized patient, if they made it all the way to the OR with the plan of cuff repair, hopefully at that time we can change the plan and do the best thing for the patient.
Yeah, agree.
One thing that I think is interesting about the sling is just how lasting it's been. I mean, like I think we've been using basically the same immobilization device since the beginning of time, it seems. So I mean, the question I have for both of you is like, are we stuck with the sling? Like, am I going to be using the same immobilization device for my entire career, or is this something that can be disrupted? Like, is there another device, like a backpack strap, platform immobilization attached to the waist? I mean, is there some other thing on the horizon that might be better, that could overcome some of the difficulties we've talked about while still having the advantages you guys discussed of early motion? What are your thoughts, Jim? And you've, I'm sure, seen the whole landscape. Do you think the sling is here until my retirement?
That's a great question. There's got to be a better way. The two most common complaints I see with the sling, and I'm sure you guys have seen this, is patients come in and they've got some pain or swelling in their olecranon bursa, and like half my patients have a dish towel padding their sling to take some pressure off their forearm. And the other common complaint is the effect of the strap on the neck. So we've moved to a sling that kind of goes over and under the shoulder, but then those are hard for patients to get on. So it seems like we don't have a great sling option. Patients don't like the slings. And that's why I let them spend a little bit of time out of the sling each day, just understanding that they don't do active motion. But there's probably some disruptive technology out there that we're not aware of. But you're right. I've been using the same basic sling concept my 21 years in practice. So I don't have any.
What do you think, Mohit? Can you design us something better? Because like I'm with Jay. Like half my patients come in and I've got the same thing. They've got like a dish towel, and they're like, I'm like the patient must think I'm an idiot, that they could have improved the device by putting a towel inside of it.
Yeah, I'm with you guys. It's a common complaint. I guess I have a two-part answer. One is I do think there probably is a future of like a better sling, avoiding the part that goes around the neck, going around kind of the upper body. Maybe we can fine tune the total time as we get better and better, sort of big granular data of how much time we need to be in the sling. I guess my other answer is more like philosophical. I feel like, like often when it comes to human suffering, it's dominated by what's happening now and what you're comparing it to. And so even if we had something better, but if they had never experienced how bad it is now, then folks wouldn't like that, the new version anyway. So I'm not sure how much it would matter in the end.
I don't think there's any better way to land a conversation on rotator cuff repair than with that quote. So thank you for that, Mohit. I think we found our sound bite. Peter has been so excited about this episode for months now, and it's really great to kind of dig into some of the classic dogma. So I really appreciate both of you contributing your expertise and really lending the highest level of evidence to this discussion.
Thank you.
I've been excited about it because I learned so much in fellowship from Jay about how to manage postoperative rotator cuff repair patients, and I've like always wished that I could like somehow share that with all of shoulder and elbow surgery, and I finally got the opportunity. So Jay, thank you so much for doing this with me.
You're too kind. Thank you.
Well, Jay and Mohit, again, thank you so much for being our guest. It's always a pleasure and a ton of fun for us to spend this time with you. For all our listeners out there, thank you for taking the time. We appreciate having you on the podcast. We really value our guests and the topics, so don't hesitate to reach out if you have any comments or suggestions. And for all our listeners out there, don't forget to subscribe, and we'll see you next time.